Greetings from National Academy of Medical Sciences, India. Focusing on NAMS Vision 2030, NAMS is pleased to share some of the important activities like NAMS National, International Fellowship and Membership, Member After Day NBIM NAMS, NAMS Task Forces, AIIMS NAMS Navigate Medico CME, CME activities, publication of annals, newsletter, networking with professionals, public orations, Young Scientist Fellowship, Scientist Exchange Program, scientific visit of Emeritus Professor and many more activities. All application forms for fellowship, membership, associate fellowship, and member after day NB have been made online and objective criteria from the year 2022. NAMS has also started a new online AIIMS NAMS Navigate CME and Navigate Medico CME program to assist in the development of competencies among students and share multimedia learning resource materials as e-library. NAMS has also started 21 task forces to address medical issues of national importance. Under publication activities, NAMS has its own annal as Annal of the National Academy of Medical Sciences. In addition, NAMS also publishes its quarterly NAMS newsletter. For more details of NAMS activities, please visit our NAMS website www.nams-india.in or scan QR codes with the camera app.
Hello and good afternoon, everyone, and welcome to the next session of AIIMS NAMS Medical Navigate CME program. So this time, this topic is really very important, and this is the need of today's time. The topic is lifestyle disorders and obesity by a prominent speaker from PGI Chandigarh, Professor Ajay Duseja sir. So to continue and to begin with the session, I would like to invite Professor Ajay Kumar Sood sir for the welcome address. Over to you, sir, please.
Thank you, Dr. Jaswant. On behalf of the National Academy of Medical Sciences, it is my great privilege to welcome the distinguished speaker for this afternoon, Dr. Ajay Duseja sir. Thank you so much, sir, for your valuable time and support to the National Academy of Medical Sciences. Dr. Duseja is the head of Department of Hepatology at PGI Chandigarh, and sir has also been the chairperson of the NAMS task force, which was particularly focusing on lifestyle disorder and obesity. So I am very sure that this session is going to be very productive and useful for all of us. So we look forward for your session. I also take this opportunity to welcome all the faculty members from different medical colleges and AIIMS, as well as the postgraduate students who have joined this session. So once again, welcome. And I hope your questions and interactive session will be very useful for all of us. So please ask questions at the end of the session. You can make the faculty members can also join and give their comments. So over to you, Dr. Jaswant.
Thank you, sir. So in order to continue the session, I would like to request our technical team for the message from President, National Academy of Medical Sciences, Professor Shiv Kumar Sarin sir. This is very important message for all the participants.
On behalf of the National Academy of Medical Sciences, it gives me immense pleasure to invite you to this National Medical Postgraduate Virtual CME program to navigate our postgraduates to become better clinicians, better physicians, surgeons, and investigators, and also to be able to get into higher courses with ease. National Academy of Medical Sciences is your own academy. It is an umbrella organization which involves experts from all fields of medicine and paramedical departments. Also, it includes researchers and eminent scientists from overseas. National Academy helps to find the best talents, to recognize them, and also to request them to teach students and colleagues across. This CME program is very special because the Friday afternoon, 3 o'clock, is with All India Institute of Medical Sciences. As you know fully well, there are about 16 AIIMS in India, and these institutions of higher learning have joined hands with National Academy of Medical Sciences. The faculty there or the experts visiting these institutes are going to give their best pieces of knowledge to students and faculty across. I feel the knowledge given through these AIIMS and NAMS CME is of immense use to all our students. The National Academy will continue to strive and improve the clinical and knowledge base of our youngsters. I am very thankful to the director, AIIMS, Dr. Srinivas, who has consented to be part of this program, and also to all other directors of AIIMS who have given their time. I encourage you to invite students, motivate them to learn, and be with us every first Friday of the month from 3 to 5 p.m. With this, I welcome today's speaker. Thank you for your attention.
Since this is a joint venture of AIIMS and NAMS, so next we would listen to the message from Director AIIMS New Delhi, Professor M. Srinivas.
Namaskar. At the outset, I congratulate the team behind the NAMS AIIMS Navigate CME program. Providing quality of education to our postgraduate students is one of the prime responsibilities of AIIMS. I know that our able faculty is leaving no stone unturned in achieving this mission. However, there always remains a scope for improvement. Through this unique initiative, there is an opportunity for our postgraduate students to learn from the experts in their field. This learning will go beyond the boundaries of department where our postgraduate students are working and will also bring in more flavor in their knowledge and at the same time ensure dissemination of uniform, high quality content all across the nation. Postgraduate students also form our primary workforce for providing patient care. This indeed is an important component of their training. We are aware that our postgraduate students devote a large component of their time for the patient care services and thus they have less time for self-study by the end of the day. The timing of this activity is therefore very carefully chosen. The sessions will be held late in the afternoon so that the beneficiaries do not have to make any extra effort for attending them. This by itself exudes the philosophy of a true teacher, a mentor that will handhold the children through the process of their active learning. As the sessions are online, which by its very design is a non-synchronous platform, it may seem that the delivery of the content will be one-sided, but enough measures have been planned and they are in place to make the activity as interactive as possible. The topic of the session will be shared with the students well in advance. This will allow them enough time to explore the subject and be better prepared to absorb the content. This design, therefore, also matches the concept and principles of adult learning. The program not only will help our postgraduate students in being better prepared for their examinations, but also will equip them with sufficient knowledge, understanding, and approach to be a better professional in their field. I wish this program all success. Thank you.
We thank NAMS for displaying the messages which are inspirational to the postgraduate students. Now I would like to welcome and invite Professor Ajay Duseja sir for the wisdom of pearls from his side on a very important topic. Before that, I would like to introduce sir. Sir is currently professor and head of the Department of Hepatology at PGIMER Chandigarh. He is also Secretary General of Indian National Association for Study of Liver. He is member of Chronic Liver Disease Foundation and NASH Committee, Global NASH Council and Global Liver Council, Asia Pacific Working Party on NAFLD, Gut and Obesity in Asia Working Group. He is also national convener for INASL Task Force on NAFLD. He is the principal investigator for Indian Consortium on MASLD. His research interests are MASLD, ACLF, viral hepatitis, and hepatocellular carcinoma. He has more than 400 publications, including more than 30 chapters in books. He has numerous awards in his name. Dharmveer Datta Memorial Oration Award, Alkem Om Prakash Memorial Award, SR Naik Memorial Award, NAMS General Amir Chand Oration Award, Inspiring Gastroenterologist of India Award, GAPIO, to name a few. So with this, I would like to now welcome Professor Ajay Duseja sir. Welcome sir. And we look forward to the very interesting presentation. We have attended previous sessions, sir. So we will learn a lot from you. Thank you. And over to you, sir.
Thank you, Dr. Jaswant. Can you hear me? Is it audible?
Sir, you are clearly audible, sir.
Okay, so thank you very much. And at the outset, my sincere thanks to the National Academy of Medical Sciences, Professor Sareen, Professor Kapil, Professor Sood, Dr. Jaswant, and everybody from the NAMS team, and also to the All India Institute of Medical Sciences, New Delhi, for this. I know this is a collaborative program. So before I go further, I'll have to share my screen. Am I allowed to do that? Yes.
Yes, sir, please.
Yeah. Are my slides visible?
Yes, sir.
Okay. So as I said, I have been assigned this job of covering the lifestyle disorders, but as I said, we'll be focusing predominantly on obesity today. And I bring greetings to all of you from PGI Chandigarh and from the Indian National Association for Study of Liver. So I'll take maybe a half an hour to 40 minutes to cover this area. It's a huge subject, but then as I said, I'll be focusing predominantly on obesity and its management and various other aspects. As we understand, and I know this is a program for the postgraduates, so what we need to understand is that when we talk about lifestyle disorders or lifestyle diseases, there are many, many lifestyle diseases which are obviously associated with our day-to-day life working. But then when we talk about lifestyle diseases, they are predominantly 6 lifestyle disorders or 6 lifestyle diseases. And to name these 6 important ones are the cardiovascular diseases, diabetes and obesity, cancers or malignancies of all kind, chronic respiratory diseases, asthma, COPD and all, and the mental health. And if you look at all these 6 important lifestyle disorders, these are all non-communicable diseases. So, many people would kind of take this synonymous also, that lifestyle disorders and non-communicable diseases are taken as a synonym kind of an entity. So these are the 6 important lifestyle disorders. And as we said, today our focus is predominantly on this one lifestyle disorder, so-called obesity. So before I go on further, let's first define what is obesity and what is overweight, and then cover all these aspects. So WHO defines obesity as an abnormal or excessive fat accumulation that might impair health of that individual. So mind it, this is the abnormal or excessive fat accumulation. But then when it comes to that, how do you measure obesity? Usually it is measured by the body mass index, which we all again understand is the ratio of weight in kgs divided by height in meters square. And for the white population, this is described as a BMI of 30 kg and 30 kg per meter square and more. But then because of various reasons and the kind of cardiovascular outcomes which have been observed to be occurring even at a lower BMI, So the cutoffs for Asians and BMI are lower than the white population. So here I have written these cutoffs for the Asian Indians. The normal BMI is taken as 18 to 22.9. Less than 18, we even call it as undernourished. 23 to 24.9 is defined as overweight, and 25 or more than that is called obesity. And obesity has in Indians or in Asians has further been divided into class 1, which is up to 25 to 30, and more than 30 is taken as class 2. So this is, as I said, based on BMI, and we will come down to the pros and cons of taking this definition. But this is what the WHO definition is, and this is what the cutoffs for Asians or Indians are for obesity. Now let's first define that what are the causes of these lifestyle disorders in general, and what are the causes of obesity in particular. So if you look at this again, there are 6 or 5 important causes of all these lifestyle disorders, and including obesity. So tobacco use, obviously could be related with various, cardiovascular diseases and chronic respiratory diseases, malignancies and all. Similarly, harmful use of alcohol has been associated with various kinds of, neurological issues, liver issues, malignancies, obesity, everything. But the 2 important ones are the physical inactivity and the unhealthy diet, which has been very closely associated with not only obesity, but also with all other lifestyle disorders. And finally, we have a data which is emerging from the risk of lifestyle disorders occurring because of pollution and various other, chemical exposures, including the plastics and the bisphenols and all these have also been linked to the metabolic disorders or maybe lifestyle disorders. So moving further, defining more of, the etiology about obesity. So predominantly people would believe that this is a kind of imbalance between the import of calories and the export of calories, which means how much calories an individual takes versus how much calories an individual burns on daily basis. This is the imbalance between that import and export, which will determine whether somebody is going to have obesity or overweight or not. Because what will ultimately happen would be that these excessive calories, if taken, would be deposited in the body, in the adipose tissue, in the form of fat. And that is what is the definition of obesity is. Now, how this imbalance between import and export happens, and this is because of this 2 important factors. One are known as the environmental factors, and others are the genetic factors. So environmental factors means that the environment is, obesogenic or obesogenic, that which means that there is increased consumption of kilocalories, and that can be because of increased food availability. It could be related to food marketing or pricing, the kind of portion size that somebody is taking, or this could be some, calorie-rich, calorie-dense foods which are available, and also the ultra-processed foods which are available, and also, by the profitable various byproducts. So this could be related to all this food availability, but this could also be related to some of the other environmental factors. For example, there is a good data which has now come in which says that your metabolic risk factors or metabolic syndrome, including obesity, could also be related to the kind of circadian rhythm somebody follows. For example, if somebody has an inadequate sleep, has increased stress, or exposure to various chemicals, which I said, bisphenols A and B, which are found in plastics, all this could also increase your risk of having overweight and obesity. So it's not only the increased import or increased intake, also it is the reduced energy expenditure, which I said, over the years, we must have seen, our lifestyle has become more and more sedentary. There is very little time to, go out and exercise. So the physical activity has reduced. That ultimately leads on to reduced energy expenditure, basal energy expenditure rates actually go down. And this creates, this imbalance between import and export, and that leads on to overweight and obesity. But then we know that all patients, those who are exposed to this kind of obesogenic environment or is exposed to this kind of environmental factors do not develop obesity. On the other hand, we can have some patients, those who are overweight and obese, without, having this kind of, obesogenic environment. So there comes the role that it is, probably beyond environmental factors, also some genetic factors could also be contributing to the causation of overweight and obesity. The time will not permit me to get into the details of the genetics of obesity. So there people have gone into various kinds of, genetic factors which are probably responsible or linked to or associated with, overweight and obesity. But the most important gene, again, as postgraduates, I feel what you should remember is this gene called MC4R gene or melanocortin 4 receptor gene. So what this gene does is, or what this receptor does is, once this receptor is stimulated by this hormone called melanocyte stimulating hormone, this increases the appetite of the individual. So, this causes more of hyperphagia, increased appetite, and patient gets more prone to overeating, and that leads on to, overweight and obesity. There are various other genes which could also be responsible. So ultimately, it is the combination of the environmental and genetic factors. And in total, these are the environmental factors which are much more important than the genetic factors. But yes, somebody who is genetically predisposed and is also exposed to the environmental factors, obviously is at a higher risk of developing overweight and obesity. Moving to the epidemiology of this ongoing, pandemic of obesity, as I said, if you take 30 as the cutoff, which is the Western cutoff, and I'll show you the Indian figures also. If you look at the Western figures of 30 for defining obesity, I mean, the data suggests that there are globally around 13% adults who are, so-called obese by this definition of BMI more than 30. But then, as I said, this could actually be an underestimate. This may not be a true prevalence because most of the non-white population, which I'll say, which have a lower BMI cutoffs, they are, kind of would be excluded if you follow this definition of 30 kg per meter square. But then the other thing is that what has happened over the years, say, for example, this prevalence of obesity since 1975 has nearly tripled. So 3 times it has gone up, and there are predictions that by 2030, this 13% figure in adults would reach maybe around 18%. And in general, we know that obesity is more common in women, and especially in the postmenopausal women, where, there's something called postmenopausal metabolic syndrome comes in, the protective effect of hormones is lost, and these ladies then get prone to various metabolic risk factors, including obesity and all its complications. But then, having said that, I think, as I said, this epidemiological figures may vary from region to region, area to area, and there's a lot of disparity depending upon what kind of groups or socioeconomics group are you picking up while assessing the prevalence of obesity. So this is the Indian data, which is a recent data. This is an ICMR data. This is an ICMR India, diabetes study data, which was published last year in Lancet Diabetes Endocrinology Journal. And this data, if you look at the figures here, this, records data of almost 12 years from 2008 to 2020, and very high number, 1,13,000 individuals have been studied in this particular study. Larger from rural area, maybe around 80,000, and maybe 30,000, 33,000 from the urban areas. But look at the figures, and this study actually gives you the prevalence of all the lifestyle diseases, all the metabolic risk factors. And if you look at this, the diabetes prevalence is close to around 11.5%. Pre-diabetes is 15%. Hypertension is 35%. But the topic of today, what we are discussing today, the generalized obesity is 28.6%. So it's a quite high figure, where you have that Indian 28% or 29% of the people having obesity. This is by the Indian definitions or by the Asian definitions, where the cutoff of 25 has been taken to define as obesity. We will come down to what is this abdominal obesity. and whether it is worse than the generalized obesity. We will discuss all these aspects. But if you look at the prevalence of abdominal obesity, it is close to 40%. Again, I think the cutoffs, I will give you the abdominal cutoffs for the abdominal obesity, but it is much more than the generalized obesity. It's around 40%, and dyslipidemias is again close to 80%. So all these, this is not alone. And this, as I said, this survey was from 2008 to 2020. But this particular study has also looked at the figures state-wise. And if you look at, all the states which you can see, but then the states where we come from, like, Chandigarh, and if you look at Punjab, New Delhi here, we all are in the red zones. Red zone means that the prevalence of obesity being 25% or more. So this is, state-wise distribution of, they have given this, if you're interested, you can go through this paper. This gives you the prevalence of all the metabolic risk factors state-wise, not only obesity, but also diabetes, hypertension, dyslipidemia, and all that. And the other thing which this paper gives you are the projections. And look at the projection. These are projections. These are the projections for 2021. We are now into 2024. But then you look at the projections of, generalized obesity in millions. 254 billions is the projection for 2021 generalized obesity. And if you look at the million projection for abdominal obesity, it was 350 million people having abdominal obesity. So I think these numbers are really, really, worrisome. And I think this also tells you that something needs to be done, this is for this ongoing pandemic. But then let me come down to, where I started, and I defined obesity by the WHO definition, where it takes into account the BMI. But then BMI has a lot of limitations while we are defining, obesity by BMI, because as I said, the definition of obesity is actually the deposition of fat. So, the BMI may not be assessing the whole fat. For example, it overestimates the adipose tissue in muscular individuals. Somebody who's really muscular has heavy bones. So his BMI may turn out to be, high, but then he may not have that much fat. So, but by definition, obesity is fat. But here the BMI would be low. And similarly, it may underestimate, the obesity in frail individuals. The BMI doesn't tell you about the fat distribution, which is the definition of obesity. It doesn't tell you about the inter-individual differences in the fat metabolism, susceptibility to adipose tissue dysfunction. Doesn't tell you anything. It only tells you about the height and weight. And then it also doesn't tell you that based on BMI whether this can help you in determining the consequences of obesity on health, because that is included in the definition of obesity. So because of this, people and the groups have suggested various other anthropometric measures which may better estimate so-called the adipose tissue mass and distribution. But that is what the obesity is. So based on this, again, for postgraduates, you need to remember, in clinical practice, we do use what we call the waist to hip ratio, waist to height ratio, and more simpler than that is what we call the waist circumference. So waist circumference is basically a marker for abdominal obesity. And again, these cutoffs are different for the white population and for the Asians and for the Indians. And for Asians and Indians, males, the cutoff is more than 90 centimeter, 90 or more. And for females, it is 80 and more. And that's why, because of these cutoffs, I showed you the figure that the prevalence of abdominal obesity in India based on these cutoffs is close to around 39 or 40%. Because we must have seen many of, especially in northern India or all over the country, we do have what is known as pot bellies, and the abdomens are kind of, protruded, and many patients would have what we call the abdominal obesity, even if their body weight may not really fit into the definition of obesity as per the BMI criteria. In addition to using these simple, things like waist hip ratio or waist circumference, people have also used various other techniques like, there are techniques to measure the adipose tissue mass, which can be based on your DEXA scans. And then we do have, the machines to measure the body water and body fat. So I think that can help you in a better way defining the adipose tissue and its consequences. Now, moving further, as I said, overall fat is very, very important. But in general, people believe that the link with the cardiovascular risk is predominantly with the visceral fat or so-called the abdominal obesity. And I'll not try to define little types of obesity and its distribution, and then we will discuss about its consequences later. So in general, when we talk about the obesity based on the body fat distribution, people divide them into two. One is the truncal obesity, which is based on your thoracic and the abdominal areas. And the second is the peripheral, which is basically your extremities, your upper and lower extremities. But further, there are two kinds of, body shapes which have been described based on obesity. One is known as the male pattern of obesity or male obesity, which is typically, apple-shaped, or also called the android obesity, where the adipose tissue is preferentially, expanded in the trunk and in the upper body area, including the abdomen part also, comes in here. And this is what we call the abdominal obesity or the visceral adipose tissue. And this is very closely associated with insulin resistance, diabetes, cardiovascular disease, and fatty liver disease. All these risks are, kind of connected. The second form of obesity is the gynoid kind of obesity, which is also known as the female pattern of obesity. And this is what we call the pear-shaped kind of, obesity, where the adipose tissue accumulates predominantly on thighs and on the hips. And they have more of, subcutaneous adipose tissue goes up. And this has been shown to be less commonly associated with all the metabolic risk factors in comparison to the android obesity, which, as I said, is more closely associated with metabolic risk factors. Going further into the body fat distribution, just to simplify what I was saying about the visceral adipose tissue, one is the subcutaneous adipose tissue. And if you can see in this figure here, below the skin, this is the subcutaneous adipose tissue. And this subcutaneous adipose tissue has further been divided into superficial and deep subcutaneous adipose tissue. And then you have the internal adipose tissue here in the abdomen. And this could be in the abdomen, in the thoracic part. So you have internal adipose tissue is intrathoracic, which could be around the heart, around the vessels, pericardial or perivascular. And in the abdomen and pelvis, this tissue is called as visceral adipose tissue. So visceral adipose tissue is intra-abdominal and intrapelvic. And this has also been divided into two, intraperitoneal and extraperitoneal. That one which is closer to the greater omentum and mesentery is called the intraperitoneal, and the other than that is known as extraperitoneal. So other than this, subcutaneous and the internal adipose tissue, which is the main storage site of fat, and once you have, this so-called the adipose tissue failure, or if somebody has, this obesity leads on to a phenomenon of insulin resistance, and this adipose tissue gets inflamed, that leads on to increased lipolysis of this fat from the adipose tissue to various other organs, and that leads on to what we call the ectopic fat deposition. And this ectopic fat deposition can happen in various organs, including your, the pancreatic fat, your renal, your muscles, your epicardial, myocardial, pericardial. And being a hepatologist, I have to talk about that this all fat, what we talk about, MASL D today, or the fatty liver today, which is again a kind of pandemic, I think is the end result of this ectopic fat deposition because of the increased lipolysis which is happening from the adipose tissue because of the insulin resistance and the adipose tissue failure, we call it, and it loses its capacity to store the excess of calories in the form of fat in the adipose tissue, and the fat goes to the various places, and that's known as, the ectopic fat deposition. So, as I said, I'll be now talking about the consequences of, this obesity and the fat deposition. And being a hepatologist, obviously, my focus will be on the fatty liver or the fat deposition, ectopic fat deposition in the liver as well. So let's start with this first, ectopic fat deposition, which, as I said, is the fatty liver, which is again a pandemic. And the Indian prevalence of fatty liver disease is close to around 40% or 38.6% to be precise in the recent systematic review and the meta-analysis, which has been done from this study of 50 studies. So which means that, and in Chandigarh, I think we had done this study, the prevalence of fatty liver was close to around 53%, which actually means that every second or every third person has fatty liver disease. And this is the end result of all this, risk factors. And the most common risk factor is what we are discussing today, is that the overweight and obesity. And the recent terminology, we know this fatty liver disease is the metabolic dysfunction associated steatotic liver disease, or MASLD. And as I said, as the name suggests, this is actually related to the metabolic dysfunction, all or these cardiometabolic risk factors. And if you look at these 5 cardiometabolic risk factors, these are nothing, but these are all the components of metabolic syndrome. So this could be your overweight and obesity, your impaired fasting glucose or diabetes mellitus, hypertension, increased triglycerides, and low HDL. I think all these 5 components are the cardiometabolic risk factors. And anybody who has one out of these 5 and also has fat in the liver based on the imaging or histology, he can be simply called as MASLD. So as I said, majority of the patient, around 80–90% of patients, at least in our clinical practice, are so-called, they have overweight or obesity or any other metabolic risk factor, and obviously have fat in the liver. But we do have patients, around 10–15%, those who are not overweight or obese by the definitions, and the definitions which we use for Indians, as I said, or where the cutoff for overweight is 23 and for obesity is 25. So they are less than 23 and they are between 18 to 23, which means their BMI is normal, but still they have fatty liver disease. And this can happen, with various other cardiometabolic diseases also. These patients are so-called lean people, but still they have this ectopic fat, or they have the visceral adipose tissue. The ectopic fat means they have fat in the liver, and the factor which is responsible for this ectopic fat is then focused on this, visceral adipose tissue. So which means they are not overall overweight or obese, but they are viscerally bad, or they have visceral adiposity, or they have visceral, abdominal obesity. And that's the culprit for these patients having ectopic fat deposition. This is one of our works where we had looked at, the visceral adipose tissue and the subcutaneous adipose tissue based on the CT scans in so-called lean people. And what we found was that the lean people, even though they had obviously less of BMI in comparison to the overweight and obese people, but when we looked at the visceral adipose tissue, there was no difference between the obese and the lean people, which means that lean people, the main problem is that they have a bad visceral adipose tissue, which is, responsible for the ectopic fat deposition. To the extent that even if your body weight is not high as defined by the BMI, but if you have, this kind of abdominal obesity, you can still have bad liver disease. And very recently, we have shown that within these lean people, those who are centrally obese, they can still have, high fibrosis in the liver, or they can have equally bad liver disease. So moving further, I think based on this, there are, suggestions which are coming, across the globe, and including from our Indian society, where we suggested that while you are, calling somebody as metabolic healthy, or when you're calling somebody as lean or obese, in addition to BMI, you should also take into account their waist circumference, and abdominal obesity should also be taken into account before we call them as whether they are metabolically healthy or they are metabolically obese. I think it's very important that we don't only talk about BMI, we also take into account the abdominal obesity, which, as I said, the simplest way to measure that is by the waist circumference. Now, moving on to the further more consequences of obesity, other than the liver disease, I think if you look at here, these have been divided into various, metabolic complications. So which could be, infertility, various cardiovascular diseases, gout, hypertension, diabetes, hyperlipidemia, all malignancies. I think everything is linked to, the overweight or obesity. There are various mental health issues which are related to overweight and obesity, and these do include even anxiety and depression and the eating disorders. And finally, we do have certain mechanical issues, like, for example, osteoarthritis, obstructive sleep apnea, gastroesophageal reflux disease. All this, can be related to your overweight and obesity. So again, the time will not permit me to get into the each consequence of obesity, but almost, they can have metabolic issues, they can have mental health issues, they can have mechanical issues. So I think the consequences of obesity are really, really large. Now, spending some time on the treatment approach in these patients with, overweight and obesity. And since we know this is a lifestyle disorder, this is related to your, your sedentary lifestyle and your increased calorie intake, in which I said in the beginning that the imbalance between the import and the export, which is the culprit. So I think lifestyle interventions are the cornerstone or are the key in treating patients with overweight and obesity in general, and all the lifestyle disorders also. So which means that I think they have to be taught about the healthy lifestyle, about their eating patterns, about the physical activity, about their sleep quality, maintaining a circadian rhythm, and also their stress management, which I said all were, these were all the causes for, the obesogenic environment or obesogenic environment, which is created by all these factors for obesity. So all these, needs to be tackled first. And those who do not improve based on the lifestyle interventions obviously then become the candidates for pharmacotherapy. And those who are not even, not improving with pharmacotherapy or are not able to tolerate the pharmacotherapy, I think the extreme steps are something called the bariatric procedures. And these bariatric procedures have now been divided into two. This could be a bariatric endoscopic procedures, or these can be bariatric surgical procedures. So maybe in next, few minutes, what I'll do is I'll now spend some time on the details of these lifestyle interventions, which are to be advised in patients with, overweight and obesity. That is how much cut in calories, how to cut the calories, what kind of diet is to be taken, and then what kind of exercise, how much exercise. And then finally coming down to, I'll tell you about the various drugs which are available to reduce body weight, and also talking a little bit about the endoscopic procedures, so-called the bariatric endoscopic procedures, and also a little bit about the bariatric surgery. So let's start with, first the lifestyle interventions to control the overweight and obesity. So in general, people believe, I think there are again lots of recommendations on this, but in general, people believe that anybody who's overweight and obese, depending upon what is your target, and you're looking at whether the liver health benefit, you're looking at the cardiovascular benefit, whether you want to look at his diabetes improvement, I think the targets in general are that they need to be advised a weight reduction of close to around 7 to 10% of their baseline body weight. And this weight reduction has to happen slowly, and which can later be sustained also. So in general, we tell our patients to lose maybe around 10% of weight, maybe over a period of 6 months. For example, if somebody is 80 kg weight, and if you tell him 10% of 80 kg becomes around 8 kg of weight reduction, but that reduction has to happen over a period of 6 months. So this is a slow and sustained kind of weight reduction, which is generally, and there is a lot of data, and some of the data I'll show you that this much of weight reduction actually has been shown to improve the diabetes control, has been shown to improve the cardiovascular health, and also has been shown to improve the liver health in patients, those who are able to lose 7 to 10% of the body weight. So how do you do this 7 to 8% weight? What kind of lifestyle interventions are required? So it is a combination of exercise and dietary restriction. Alone can also work, but then there is good data to support that it's the combination of dietary restriction and the exercise which works better than diet alone and exercise alone. So how much diet reduction is to be advised? In general, again, the guidance would say that you should tell your patients to cut down their calorie intake maybe by 30%. So 1/3 of calories need to be cut, because severe calorie restriction or so-called severe hypocaloric diets are usually not recommended, and these sometimes can be counterproductive also. So around 30% weighted, 30% cut in the calories need to be done. Again, I think the simple example for that could be, and this, reduction has to be predominantly on carbohydrates and fats, and the proteins may not be reduced. So how do you tell somebody that you need to reduce 30%? For example, if somebody is taking in his or her meal, maybe 3 chapatis in one particular meal, so 1/3 kilocalorie reduction means would be that has to be reduced to maybe 2 chapatis now. So similarly, a portion of rice, if somebody is taking, that portion has to be cut down by 1/3, and you're trying to reduce the calories by 1/3. There are, charts available. There are dietitians available. They can give you all details, in detail, that how much carbohydrates, fats need to be cut. But in practice, I think these are the simple things which need to be told to your patient. The other things which need to be told to these patients is to cut down on the saturated fat, cut down on the trans fat, cut down on the added sugars, cut down on the saturated fat, and follow the principle, I'm saying the principle of Mediterranean diet. We can't have the Mediterranean diet in India here, but the principle is that more of, fruits, more of, healthy, the green leafy vegetables, and then you can have and avoid, as I said, the food, the sweets and the fructose rich, beverages, and all, these things have to be avoided. And I think this is the concept of Mediterranean diet, which, has to be followed in them. Now, in addition, as I said, the diet alone will not work. You have to combine it with exercise. Now, how much exercise and what kind of exercise? So it is usually the aerobic exercises which work better, but it could be a combination of aerobic and anaerobic exercises. And aerobic exercises, when we say, it basically means brisk walking, running, jogging, swimming, cycling. All these are, aerobic exercises. And the anaerobic or resistance exercises are so-called the bands and the dumbbells, and all those kind of exercises are the anaerobic exercises. So a combination is usually better, because the resistance exercises also tends to build your muscle, and which is also very important for the overall health and the liver health and the cardiovascular health. And so it has to be a combination. But then if somebody is, say, for example, doing this exercise, so in general, it has to be every day. If not every day, at least 5 times a week is the target which is usually given. So if somebody is exercising, how much every day, or in total, how much per week? So in general, moderate intensity exercises close to around 150 minutes per week is usually considered as sufficient. So which means if somebody is exercising for 5 days a week, maybe 30 minutes every day, or 30 minutes to 45 minutes every day, into 5 days becomes around 150 to 200 minutes or per week. I think that's usually considered as good. So as I said, this is a combination of, and especially for those who are not able to do the aerobic exercises, what do you do that? And there, as I said, I think you probably have to advise them more of anaerobic exercises, dumbbells and the other things, for those who can't do the aerobic exercises. So moving further, as I said, there's a lot of data which is available now, where people have shown that the lifestyle interventions can improve your end organ damage. And this is, the compilation of some of the studies on diabetes, where studies have shown that people, those who adhere to lifestyle interventions, there is improvement in their diabetes control. And if you look at this, weight reduction of maybe 5 to 7%, I think did cause, partial or complete remission of diabetes or control of diabetes here. Similar data is available for liver health also. Again, if you lose, around 7 to 10% of weight reduction, there's data to suggest that it improves not only fat in the liver, but also inflammation and maybe fibrosis as well. Now, moving further, as I said, there are patients, those who will not be able to exercise. There will be patients, those who will not be able to lose the desired amount of weight on exercise. And there will be patients, those who are lose initially weight on the lifestyle intervention, but will also gain. And the last group would be that patient, those who already have end organ damage. So these 4 groups of patients, I think you would like to add anti-obesity medications to their lifestyle interventions. Now, again, there's a long list of medicines which are available. And again, the time will not permit me to get into the details. But I think just to name for the postgraduates, again, phentermine, topiramate combination, naltrexone, bupropion combination. I mean, these are all FDA or EMA approved drugs which are available. But now the drugs which are now coming up in a big way are so-called the glucagon-like peptide GLP-1 analogs. So initially the drug was called the liraglutide, and now we have a better drug which is called the semaglutide. Both these are, GLP-1 analogs which are available. And then there's another drug which has now come in, which is again very, very useful and powerful, is the combination of the GIP and GLP-1 dual agonist, and the drug is called tirzepatide. So, these are the drugs which are coming up, as I said, and have been approved by FDA and EMA for patients with obesity for use and for weight reduction. Now, again, if you look at the data which is available for these drugs, if you look at these first generation anti-obesity drugs like naltrexone, bupropion combination, or phentermine plus topiramate combination, I think the weight loss was not much, close to maybe around 5-7% weight reduction. But if you look at the next generation or the present generation, anti-obesity drugs, which I said semaglutide, which is a GLP-1 agonist, the weight reduction can be as high as, 12 to 13%. And with tirzepatide, it has been shown to be as high as 17 to 18%. But then, as I said, this is the overall weight reduction, but then if you're looking for only 5% weight reduction, if you're looking for only 10% weight reduction, these drugs are very, very powerful. And then 5% and 10% weight reduction can happen in 80 to 90% of individuals with these drugs. And I'll show you some data on this. And this is, the study, so-called, these are the drugs called are the step 1 studies, which are the multiple studies which are available. But I'm quoting this study, this study was done in adults by this once weekly semaglutide. Semaglutide is an injectable drug which is given subcutaneously once a week, GLP-1 analog. The natural GLP has a very short half-life. So this analog semaglutide, which is a synthetic, GLP-1 analog, has a long half-life, and you have to give this only once a week. And this has actually been shown. And this particular study, if you look at this is published in NEJM in 2021. 5% weight reduction was observed in around 86% of patients with semaglutide. 10% weight reduction in around 70%, and 15% weight reduction in 50%. So I think these drugs, as I said, are now have been approved. In India, we don't yet have the injectable semaglutide which is available, but we do have an oral semaglutide which is available, but then the injectable semaglutide is still awaited. Then thereafter, we do have a data of this drug not only in adults, but also in adolescents, and almost with similar efficacy. And this drug has also been used in patients with fatty liver disease. And there also it has been shown to improve the end organ damage, which means improving fat, inflammation, and a bit of fibrosis. And again, the mechanism is probably, by weight reduction. And to the extent that people have used this even in a severe form of liver disease, for example, in cirrhosis, there it was not found to be useful. But then it was even in that particular group, this did cause the weight reduction. The desired weight reduction was observed even in patients with cirrhosis. The second drug, which I said is a GIP and GLP-1 agonist, is a tirzepatide. It's again a once weekly drug. And again, if you look at this, the 5% weight reduction, 10% weight reduction was seen in significant number of patients with tirzepatide. Again, this is one study of tirzepatide even in patients with fatty liver disease. Finally, I'll just take last, 2-3 minutes to briefly tell about the postgraduates about, the various other modalities which are, interventions, we call it the endoscopic interventions and the surgical interventions to control obesity, where your lifestyle interventions are failing and your drugs are failing, or drugs are, are not to be used. I think there people have tried, various endoscopic interventions. We will come down to that. What are the indications of using these endoscopic interventions or the bariatric surgery? But this is one data, and there are various kinds of endoscopic devices which are available. But the two common ones are one are called the intragastric balloons. You put balloons in the stomach, reduce the area, cause hormonal changes. Your appetite will go down, ghrelin will go down, and ultimately your stomach capacity is also reduced. The stomach is full with this balloon. This has been shown to improve the overweight and obesity, and also your end organ damage. Similarly, there's another endoscopic modality which is known as sleeve gastroplasty, endoscopic sleeve gastroplasty, which has been shown to cause improvement in all the metabolic risk factors, including weight loss, including HbA1c, and also the end organ damage. So, as I said, what would be the indications of doing these bariatric procedures, whether this is the endoscopic procedures or these are the bariatric surgery procedures? In general, in the Western population, people would recommend them, those who have, say, for a BMI, which is obese, more than 30, but with another uncontrolled metabolic issue, for example, say diabetes. But those who are, no other metabolic issue, no other comorbidity, there the cutoff for using these modalities is BMI of more than 35. So for us Indians and Asians, as I said, you probably have to reduce this by 2.5 to make them eligible for these, but mind it, these are to be used only in situations where your lifestyle interventions have failed. Only then you can think about, metabolic surgeries or metabolic endoscopy as a procedure. So lastly, the bariatric surgery, again, are of various kinds, but the 2 or 3 which are commonly done, one is the Roux-en-Y gastric bypass, other is the vertical, banded gastroplasty. But most of people would be very comfortable in doing what they call LSG or laparoscopic, sleeve gastrectomy. So I think the time will not permit me to get into details, but there's good data to compare these surgical interventions with the lifestyle interventions, and they have been shown to improve not only overweight and obesity, but overall metabolic health has improved. So ladies and gentlemen, let me summarize what I said in last half an hour or so, is that, lifestyle disorders are huge challenge for us, but then 6 important lifestyle disorders are the cardiovascular, respiratory, malignancy, mental health, diabetes, and the obesity. The focus today was on the obesity. In general, prevalence of obesity globally figures are 13-14%, but Indian figure, the recent study which I showed you, generalized obesity of 28%, and abdominal obesity, which is considered to be so closely associated with metabolic risk factors, is close to around 39%. The pathophysiology is basically the imbalance between your import and export of calories, and it's the obesogenic, environment which comes in, and the less of physical activity and the sedentary lifestyle, and the genetic factors could also be contributing. We discussed a bit of consequences of obesity, including that it can involve all the systems, starting from cardiovascular to malignancies to liver to everything. And the treatment, the crux is basically on the lifestyle interventions, which has to be done with diet and exercise. And those who are not able to lose sufficient weight with diet and exercise or with lifestyle interventions, there you can maybe take the help of anti-obesity drugs, and a lot of research happening there. And the 2 promising molecules are the semaglutide and tirzepatide. And finally, I think there could be a little role of the bariatric endoscopy and surgery in those where lifestyle interventions and rest, everything is failing. So with this, I think I'll stop here, and I'll be happy to take any questions. And let me stop sharing my screen. Thank you very much.
Thank you very much, sir, for the wonderful lecture. And I would say, sir, it solved many doubts. Like your lecture was self-explanatory. Like many doubts which I personally which I had were solved like in the next few slides. So it was really a wonderful presentation, sir. Thank you.
Thank you.
Sir, there are several questions. Few are from YouTube and few are asked here on the Zoom itself. One question that we often advise both physical activities and dietary changes for better results. However, there are many patients who are confused by the YouTube videos. So for the patients with coronary artery diseases, is dietary restriction alone is sufficient?
No, I know. I think because of the paucity of time, I couldn't get into those details. But yes, there are lots of clinical challenges which happen. And I just gave one example that, for example, somebody has, say, for example, has osteoarthritis, severe osteoarthritis, and obviously can't exercise. And if you are advising him weight reduction, and that vicious cycles, comes in there. So there, that particular situation, we tend to advise them so-called the resistance exercises like bands and dumbbells. But cardiovascular, disease is also a very big challenge. It's a very big challenge because, what is your exercise capacity has to be seen. And that cardiac capacity has to be, seen by maybe by a stress test, or has to be evaluated by a cardiologist. We just can't, somebody has a coronary artery disease, we can't give him the same targets of exercise which are being given to somebody who doesn't have a cardiovascular exercise. So that has to be assessed by a cardiologist, right? And the exercise capacity has to be evaluated before he's told that. Now, whether alone diet will be helpful in there, the answer is that it might help partially, because as I said, alone diet, alone exercise is obviously weaker than a combination of the two. But yes, I think since we do not have a choice, and if there's a very poor exercise capacity, I think we have no choice but to cut down only on calories.
Right, sir. Right, thank you. Sir, next question is from Mr. Neeraj P. He asked, sir, is there any role of early dinner, say before 8 p.m. in the weight reduction compared to the late dinner?
No, absolutely. I think when it comes to saying this, absolutely, it's very important. People would say that nothing after sunset. Many people would believe that you should not be taking your metabolism, your circadian rhythm, everything changes, with the late, consumption of all these calories. Yes, I think again, there's good data to suggest that yes, early dinners, early supper or early dinner or before the sunset, I think is very important in maintaining your metabolic health.
Right, sir. Right, sir. The second question from the same person, Mr. Neeraj, is grade 2 fatty liver, non-alcoholic, reversible through dietary modification or weight reduction only?
Yes, absolutely. There's a huge data again which is available. Fatty liver, when we say fatty liver, it has three components. One is fat in the liver, and around 1/3 of them start having what we call inflammation, and then osmosis as well. So out of these three things, the most reversible is actually fat. So fat you can reverse even with weight reduction of only maybe just 3 to 5%. But then if you're looking for reduction in inflammation, then you require a weight reduction of maybe 5 to 7%. But if you're looking for fibrosis reduction, you require a weight reduction of 7 to 10%. So that's why I said normally in clinical practice, we give our patients a target of 10%. And even if he's able to lose 5%, I think we tend to achieve the target which is required here.
Right, sir. Sir, next question is from again YouTube. Thank you, sir, for guiding us on this important topic. Are all the anti-obesity drugs you mentioned available in India?
Yes, the oral first generation drugs are definitely available. As I said, semaglutide is the king now, or GLP-1 agonists are coming up in a big way. So GLP-1 agonist injectable is not available, but the oral is available, semaglutide, which is available. And many endocrinologists are using this oral semaglutide for control of both overweight and obesity. And it also has anti-diabetic effect. So those who are overweight and obese with or without diabetes, there I think oral semaglutide is being used. I feel there are only two challenges for using this drug. And one of them is that it's cost. And the second is the side effects. So, these GLP-1 agonists, both injectable and more with oral, are associated with a lot of GI side effects. So, they have a lot of, nausea, bloating, constipation. I think that's what we have used this oral semaglutide in our patients with fatty liver disease. And we have shown that, yes, they do have weight reduction and improvement in their fatty liver as well. So I think with these challenges, and the second side effect is that these particular group of drug GLP-1 agonists, they also lead on to elevation of amylase and lipase, and uncommonly even pancreatitis and the occurrence of gallstones. So I think with all these, risks and all, but these drugs look very, very effective. As I said, people have shown the weight reduction of even up to 15 to 20% with the GLP-1s.
Right, sir. Thank you, sir. Sir, another question in the same line. For a LAMI country like ours, which drug is best as per efficacy cost ratio?
Okay, for the weight reduction, they're asking
Right,
which drug
right,
is
sir.
best.
Right.
As you said, the problem with these newer drugs, which is the GLP-1 and maybe the later the tirzepatide also comes in, and there are a few more in the pipeline which I didn't speak about. The problem right now is the cost, definitely. So I think if somebody cannot afford these drugs, yes, and as I said, affordability is an issue. So time-tested other drugs, which are, for example, in diabetes. I mean, very cheap drug is so-called metformin. So metformin is a very good drug, and especially for obese diabetic. It's a very cheap drug, and if somebody obviously can't afford these, the newer generation costly drugs, so simple drugs like metformin, which will not only control your diabetes, but they also cause weight reduction. I think drugs like those can be used. And the first generation drugs, which I said, naltrexone and all, they can also be used, but then their efficacy is lower. So it all depends on how much weight reduction are you looking for. If somebody is 150 kilo, and then you obviously need little more drugs or powerful drugs, and which are more efficacious than just causing drugs which are causing only 3 to 5% weight reduction.
Right, sir. Sir, there is another question from Miss Megha. What is your take on intermittent fasting, sir?
I think that's a very important question, and again, I couldn't touch that because of the paucity of time. So, there are various kinds of intermittent fasting, and intermittent fasting has been in practice in India at least, or in otherwise also in many countries, for last many, many years or decades, I would say. People do fast, and then so there are various kinds of regimens which are available. But the most commonly regimen which people use is so-called the 16:8 regimen, that you eat only for 8 hours and 16 hours you are kind of fasting. Some people do use what we call the alternate day fasting and various kinds of things. So as far as my personal experience is concerned, we have used this intermittent fasting in our patients with fatty liver disease. And we did this randomized study and divided them into two groups. So, but what we found was that ultimately, intermittent fasting was as good as the other lifestyle interventions in reducing weight and in improving your fatty liver disease. So the message here is that if you are able to reduce the desired body weight, say 5%, 10%, by your routine lifestyle interventions, then intermittent fasting is not adding anything extra. But then if you're not able to lose the desired weight with the routine lifestyle interventions, then yes, I think the intermittent fasting may help you. But the targets achieved of weight reduction may be similar, in both the kinds of regimens which you follow. And the end organ improvement, for example, say let's talk about improvement in fatty liver, which may be similar whether you lose weight by the routine lifestyle interventions or you lose weight by the intermittent fasting. So ultimately, it is the weight reduction, right? So if you're able to lose it by the routine lifestyle interventions, then I think it's fine. But if not, yes, intermittent fasting is one way of improving, that skill.
Right, sir. Thank you, sir. Sir, one question from my side. Like, I'll ask one question. I'm basically from Haryana.
Right.
So, the one advice that we often suggest to our relatives, not our patients, who are overweight. So often we ask them to restrict their diet. They often do sufficient physical activity, but they are unable to restrict their diet mainly in the form of paratha and butter and like other stuffs. Since you are practicing for many years in Chandigarh, so I think you are the best person to answer. At times, once we advise them to restrict their diet, then they will say कि सर हमारा तो जिंदगी का क्वालिटी खराब हो जाएगा, मतलब ये इसके बिना हमारा जीवन चलता ही नहीं है, सुबह ना खाओ तो
Hmm.
दिन नहीं निकलता है. So
Right, right.
what's your take and how you address this thing, address this issue? And seriously, it at times it impacts their daily routine if they completely restrict their usual food habit. Like now they are 55 or maybe 60, so they have been taking this diet for so many years. Now like changing it immediately, it may like
No, no,
so.
absolutely. I agree with you, and I think for this the general advice what we give is, I don't know whether if you understand Punjabi or not. We tell them थोड़ा खाओ रज के खाओ. तो थोड़ा खाओ रज के खाओ का मतलब है कि you have
Right.
to, the quality of life is very important. I think yes, that's equally important. The weight reduction and other metabolic health is important, but quality of life is equally important. तो थोड़ा खाओ रज के खाओ का मतलब है that you can have everything, but you have to cut down on your portion, and you must get satisfied even with that small amount. So even if they want to have pranta or they want to have butter, that control is very, very important to keep a check on that portion, right? Not having 3 or 4 paranthas with, 250 grams of butter, so that control on portion is very, very important. So thoda khao, raj ke khao.
You're right, sir. This is the best advice, sir. And now I'm like 100% confident in answering them.
Right.
So thank you, sir. So like this topic of dietary modification, sir, like the YouTube and Instagram nowadays are flooded with such videos, but there was dire need of a scientific video and presentation for
Right.
this important topic, sir. So as Sood sir already mentioned, that this video will be uploaded on YouTube, and also this will be shared on the website of NAMS. So it will be very helpful for the doctors and also for the common people of the India.
Thank you.
So thank you very much, sir. Now I would like to request Professor Sood sir for delivering a word of thanks. Over to you, sir.
Thank
Thank you
you.
so much. Thank you, Dr. Jaswant. I am really grateful to Dr. Ajay D'Souza, sir, for covering this complex topic in a very simple way. And the way you have explained the management of obesity, I think it is really, all of us have learned a lot from. And especially the tips which you have given to our students, I think they are very, very important. So we are really grateful to you for your time and support and blessing to National Academy of Medical Sciences. And we look forward for your continuous support, sir, in future also. We are really grateful to you, sir.
Thank you.
Uh,
Thank you very much. Thank you.
We also like to thank all the directors, deans, and faculty members of AIIMS and medical colleges who have sort of contributed to our program by participating and also encouraging the PG student to attend. Now we have more than 1,000 students who are registered for this Navigate program. I also want to make another appeal to all the faculty members that please have NAMS cell in your medical colleges. Right now, we have 62 medical colleges which have NAMS cells, and these cells are basically helping the academic activities of the National Academy of Medical Sciences. For example, you can have CME program, short-term CME program, maybe 8 hours program, and National Academy will be happy to financially support those programs. So this CME program even could be arranged for postgraduate students. So when we have this NAMS cell in the medical colleges, the basic purpose basically is to facilitate these activities. So you can designate one of the senior faculty member that this person is our nodal officer of the medical cell, and we will communicate with him and we'll send him all the related material related to training. For example, we have newsletter, we have a journal. In addition, we also have task forces. So all these related academic activities will be through them. So that will be very important, I think, a unit of National Academy. So I will appeal once again to all medical institutions to designate one senior officer as a NAMS cell nodal officer, and just send an email to us with the name designation and the contact detail, and we'll send all the details. I also take this opportunity to thank all the students and participants who have attended this evening and made this session very interactive by asking the question. So this is your own program, so please participate and also encourage other students to join us. For the information of the student, I would like to mention that yesterday we have launched a National Biostatistical Helpline in collaboration with Indian Council of Medical Research. So this is online support to all the PG students from all across the country. If they have any question related to their thesis, any query related to their thesis, eminent biostatistician and epidemiologists are available online and they can help them guide. So it is not going to replace the routine mechanism, but just to add on to what the existing facilities are there in medical colleges. There are some medical colleges where statistician may not be accessible that easily. So this online will serve that purpose. Then on this online, some of the faculty members who want to volunteer as a resource person, they can also join. So all these details we have put on the chat box, so you can look into that. There is another information related to a online short-term training program on artificial intelligence in healthcare for medical professionals. This program now NAMS is launching with the international IIT Hyderabad. This is International Institute of Information Technology Hyderabad, and this program is being launched from 15th of September formally, but you can register immediately, and we have again circulated the brochure for this in the chat box. Basically, this is online program which is about 12 weeks, and every week there will be 3-hour session. 1-hour session will be taken by the expert for giving the theoretical concept. Another hour will be spent on contact, sort of clearing the doubts and demonstration. So basically it will be 3 hours per week, and all the details are available in that brochure which we have circulated. So please, especially the postgraduate student and young faculty who want to join this, that will be a useful program for all of you. The next Navigate session we have scheduled for 20th of September, and there again we have a very interesting session on alcohol and drug abuse by Professor Rakesh Kumar Chadha. Sir has been the former head of department of All India Institute of Medical Sciences. So I will request all the PG students to again join. And if you have some questions, specific question, you can send us the email, which we'll put to the expert for answer. So I will also like to thank Dr. Jaswant, who has been helping us from the very beginning for his valuable support. And thank you, Dr. Jaswant. Even you have gone to AIIMS, Deoghar, but still you are helping us. So we are really grateful to you for your support. And here we have Mr. Ravi, our IT expert, and Mr. Shivam, who have been helping us in organizing this program on Zoom as well as the YouTube and writing letters. So once again, I thank you all for being with us this evening, and special thanks to our guest faculty, Dr. D'Souza sir, for being with us and sparing your valuable time. Thank you so much.
Thank you. Thank you. Bye-bye. Bye-bye.
Thank you, sir. So
Thank you. Bye-bye.
this we can conclude.